Good evening, everyone, and welcome to the second session of MCQ discussion on orthodontic and endofacial orthopedics. So today we'll be discussing a few more questions which are very important and related to very important concepts that may be asked for your coming examinations. So we'll directly go to the next question discussion. The first question, this is actually very simple. The Leeway spaces. The combined mesodistal width of permanent canine and premolars is usually less than that of the deciduous canines, first molars and second molar. So you can directly opt the answer as option A. Now, what is Leeway space? The Leeway space is the difference between the combined width of deciduous canines and molars when you're comparing it with the permanent canines and premolars. So that's the amount of leeway space in maxillary arch is 0.9 millimeter per side, and in mandibular arch it is 1.7 millimeters per side. So this space, that means the difference in this dimension is very important, and it has very importance in getting a class 1 molar relation in permanent dentition. We'll discuss about it sooner. Now just see this question. Incisal liability in non-space primary dentition is compensated by. So the options are leeway space of Nance, which is absolutely the wrong answer. Then primate spaces, increase intercanine width, and interdental spaces. So what is this incisal liability? So when you see the mesodistal dimension of permanent incisors, when you're comparing it with the deciduous incisors, the permanents are having more size compared to the deciduous teeth. So for the deciduous teeth to erupt, it requires about 7.6 millimeter of space in maxilla and 6 millimeter space in the mandible. So this difference is called as incisal liability. This is actually overcome by the first method is utilization of the physiological spacing, which is actually present in the deciduous dentition. And the second method is the increase in intercanine width. And the third method is change in angulation of incisors. So usually the incisors, the permanent incisors will be erupting labial to the deciduous incisors. So by erupting so, there will be change in angulation of the incisors. So the interincisal angle is getting lesser in permanent dentition. So these are the three methods by which the incisal liability is overcome. Now see the question. In the question, it has mentioned that it is a non-spaced primary dentition. That means there is no physiologic spacing or primate spacing in the dental arch. So the option A, we have already deleted the option A because that is leeway space has nothing to do with this incisal liability. Then primate spaces and interdental spaces are also absent in a non-spaced primary dentition. So the correct answer is increase in intercanine width. Moving to the next question. Which of the following will lead to class 2 malocclusion? We have already learned from in the first year itself, when the deciduous molars erupt, the posterior surface or the distal surface of the upper deciduous molar will be in line with the lower deciduous molar. So this is called as the picture B is called as the flush terminal plane. The option A shows a mesial step and option C shows a distal step. Now what happens to the permanent molars once they erupt? See this image. The second image shows the flush terminal plane in which the deciduous molars are actually present. So this flush terminal plane gives a guiding posterior plane through which the permanent dentition or permanent first molars can get erupted. So when the permanent first molars are erupting, they will be in an end-on relationship. Later on, by utilization of the leeway space of Nance, which is gained by the loss of deciduous molars, the lower molar and upper molar will be migrating more. And you have already seen that the leeway space is more in the lower arch. So compared to the upper permanent first molars, the lower permanent molars are going to move mesially more. So because of this forward shift of teeth, it can shift to a class 1 molar relationship. Along with this, the forward growth of the mandible will also aid in obtaining a class 1 molar relationship. So if the deciduous dentition is in a flush terminal plane relationship, the teeth, that is the permanent first molars, will be erupting on a end-on molar relationship. Later on, because of the mesial shift used by the utilization of leeway space and because of the forward growth of the mandible, it will become a class 1 molar relationship. Now, what happens to the mesial step and distal step? See the distal step, that means the distal surfaces of the deciduous molars are having a distal step. That means the permanent first molar will be erupting in a distal relationship, which gives a distocclusion or a class 2 molar relationship. So because of the loss of deciduous dentition or by the utilization of the leeway space, this lower molar can get migrated slightly mesially. So depending on the mesial migration, it can be in a class 2 molar relationship or become an end-on molar relationship. It can never become a class 1 molar relationship. Okay. Now about the mesial step. In the case of mesial step, with minimal growth differential, it will maintain in a, or it will be maintained in a class 1 molar relationship, because when the deciduous dentition is in a mesial step relationship, the permanent first molars will be erupting in a class 1 relation or near class 1 relation. So if the mesial movement because of the leeway space is minimal and the forward growth of the mandible is minimal, then this mesial step malocclusion will be maintained as a class 1 molar relationship. Suppose, or most commonly, if there is more mesial movement of the lower molar because of the utilization of leeway space and because of the growth of the mandible, it will become a class 3 malocclusion. So generally, distal step will be maintained as a class 2 or an end-on. Flush terminal plane will definitely become a class 1, or if the mandibular growth is very much, then it will become a prenormal molar relationship. And the mesial step will be maintained in the class 1 molar relationship if the mandibular growth is deficient, or it will become a class 3 if the mandibular growth takes up. So in this question, which of the following will lead to a class 2 molar relationship? The answer is option C. That means a distal step distal step plane will be leading to a class 2 molar relationship. Now going to the next question. Self-correcting anomaly among the following. This is a very simple question. The answer is ugly duckling stage. Now, let's discuss about the different self-correcting anomalies in development of dentition and occlusion in human beings. The self-correcting anomalies or transient malocclusions are classified into different developmental periods. So first one is pre-dentate period, second one is deciduous dentition period, and mixed dentition period. So in pre-dentate period, there will be retrognathic mandible, anterior open bite, and infantile swallowing. See, these are the gum pads, upper and lower gum pads. There is contact only in the posterior region, and the anterior region will be giving an open bite. So this is the open bite, which is a self-correcting malocclusion you can see in a pre-dentate period. Now, see this. This is an image of an infant in which you can see that the forehead and the maxilla are taking up growth, but see the mandible, it is retrognathic. But by the further development of the mandible, it will take up growth and it will become orthognathic. And the third one is infantile swallow. Actually, this infantile swallowing is a very helpful mechanism which is helping the child to feed. See that the tongue is protruded between the upper and lower gum pads, and the nipple is kept in between the tongue and the upper gum pads. Now, the child has to hold the mandible. So, in children, the muscles of mastication will not be developed as much as in order to hold the mandible in position. So, in children, since the mandibular growth is deficient, the mandible is kept in position by the activation or the action of the facial musculature. That means it is controlled by the seventh cranial nerve, that is facial nerve. So all the facial nerves will be activated for this suckling action, in which the child holds the mandible protruded, keeping the tongue forward between the nipple and the lower gum pad so that there is a negative pressure is created inside the oral cavity. So the lip seal is created by the facial muscles and negative pressure is obtained inside the oral cavity. Now the the child has to swallow. Now the swallowing is very different in a child. An infantile swallow is characterized by the peristaltic movement, which is starting from the tongue itself. So the peristaltic movement will be starting from the tongue, which is followed to the remaining portion of the alimentary canal. Now, the furrowing of the tongue in the middle portion will collect the milk inside the mouth. And later, the patient or the child will be swallowing by passing this milk between the facial pillars. Since the larynx is open, the child can continue breathing, and at the same time, the child will be able to swallow the milk through the pathway between the facial pillars. Now, we have to understand that the swallowing in the infants will not be interfering the respiratory process of the child, because when the child respires, the epiglottis is kept open, but the milk is not flowing through the midline. Instead, it is going through the lateral walls of the pharynx between the anterior and posterior facial pillars. Now, the remaining self-correcting anomalies are deep bite, flush terminal plane, primate and physiologic spacing. All these we have already discussed about this. The deep bite will be corrected in deciduous dentition period to certain limit by the eruption of the permanent molars. Then in mixed dentition period, it will be corrected once the second molar are getting erupted in the permanent dentition. So all these are self-correcting anomalies which are observed as anomalies, but later on the development of dentition and occlusion will get corrected. Now going to what is ugly duckling stage. It is a special characteristic which can be seen in children of 8 to 9 years of age, which is put forward by Broadbent. Why? That's why it is called as Broadbent phenomenon. Now, because of the eruption of the permanent canines, which is traversing along the lateral surface of the developing root of lateral incisor, the canine will be guided to occlusion by the root of the lateral incisor. So this canine the canine is the most traveling tooth in the oral cavity, because it has about 22 millimeters to travel to reach into plane of occlusion. So the canine cusp will be traversing or traveling along the lateral border of the root of the lateral incisor. So because of the developing crowns of the canines, the incisors will be slightly tipped. That means because of the pressure of the erupting canine, the lateral root will be impinging onto the roots of the central, and the central will be impinging to each other. So because of that, there will be a space opening in the midline as a midline diastema. And later, by the eruption of the further remaining eruption of the canine, space will be completely closed. And you have to make sure that the space between the two incisors is not because of the thick or highly attached frenum, labial frenum. If it is so, you have to intervene the frenal attachment in the later stages. But during this age period or age group, we have to wait and see how much the midline diastema is getting corrected. Now, the space is less than 2 millimeters. Mostly, it is likely to be closed by itself. It is more. You have to check for what is the actual reason for the maintained midline diastema. This is about the ugly duckling stage or Broadbent phenomenon. Now, see this question. So they have asked us to match the given options: cheek biting, incorrect arch form in posteriority, clicking, increased vertical dimension, tongue is cramped, constricted arch form. Actually, these are correct options which are given in the same option. Now, the matching is correct. Now we have to think about how it is getting matched. In the option B, please don't get confused with the clicking of TMJ. They haven't mentioned it as clicking of TMJ. Instead, it is actually the clicking between the teeth that we will see soon. Now, when we think about the cheek biting is actually caused by different factors. First one is buccoversion or buccal flaring of erupting third molars. Since the buccal occlusion is not correct or not perfect, there is opening of the or flaring of the upper posteriors, there will be chances of the cheek getting between the upper and lower posteriors, which will cause the cheek biting. Then flabby cheeks, lack of proper coverage of lower teeth by upper teeth buccally. That means the proper intercuspation is very much important for having a proper chewing by the posteriors. So if the proper coverage of the lower teeth by the upper teeth is not present, that will also can cause cheek biting. Then atrophy of muscles in paralysis because of the imbalance between the muscular forces can also create or can also cause cheek biting. Then the maxillary posterior teeth, especially the second molars, must be arranged to provide adequate buccal overlap to minimize cheek biting. See, there is an overjet called buccal overjet. That is the transverse overlap between the upper and lower buccal teeth. So the sufficient buccal overjet is required to avoid or not having a cheek biting habit. Now about the clicking sound. Actually, the vertical dimensions more, there will be increased vertical growth of the mandible. Along with that, there will be over eruption of the upper posteriors too. So this can create a clicking because of the contact between the upper and lower posteriors. That is what mentioned as clicking here. So clicking sound, the embarrassing clicking sound may be heard from vertical growers. So in vertical growing individuals, the clicking of the teeth can be heard. And cramped tongue, it's very simple. If the posterior teeth are lingually set or lingually erupted or lingually rolled in, that can encroach into the tongue space. That can cause cramping of the tongue. So in the previous question, all the matches were correct. See this question. The skeletal classification of malocclusion is given by. So before answering this question, you have to go through which are the contributions by all these scientists as in the classification of malocclusion. Now, first thinking about the father of modern orthodontics, Edward Hartley Angle, he classified the malocclusion into class 1, class 2, and class 3 based on the sagittal position of permanent molars, first molars. Then Martin Leeway is the one who classified the class 1 and class 3 malocclusions based on Angle's classification into different subtypes. Class 1 into 5 types and class 3 into 3 types. In Calvin case, is the one who classified class 1, class 2, and class 3 malocclusion in a very elaborated manner and a very difficult manner. He has divided class 1 into division 1 and division 2, in which he has given 7 subtypes for division 1 of class 1. In class 2 division 1, he has given 2 subtypes, and class 2 division 2, 4 subtypes. And the entire class 3 is divided into 4 divisions by Calvin case. So all these 3 classifications are dental classifications. So these 3 cannot be the answer. Now, when we are talking about Paul Simon, he is the one who gave the Simon's classification, which is actually based on gnatostatics and canine law. So he has taken 3 planes, and based on that gnatostatic planes, he has classified the malocclusion. So among these 4 individuals, Paul Simon is the one who classified the malocclusion based on skeletal base or on the basis of skeletal relationship. That is why the option A is the correct answer. Now I have to add some knowledge about different classifications and different classification techniques. Please go through this. So the first thing is Samuel S. Fish. He is the first to classify malocclusion into 4 states of irregularity. He's the first one who correctly classified, or who's the first one to classify the malocclusion for the first time. And George Carabelli, he's the first to classify in a systematic manner. Then Benno Lischer, you know this classification: nutroclusion, mesocclusion, distoclusion. Then Strang is the one who classified the malocclusion based on the body of mandible. This is the only classification given on the basis of body of mandible. Then Jacob A. Salzman, he is the first one to classify skeletal relationship as skeletal class 1, skeletal class 2, and skeletal class 3. You have learned this classification in your clinical practice or in clinical postings in which you use two-finger technique to classify the skeletal base into class 1, class 2, and class 3. And the skeletal classification, the extraoral technique was put forward by T.D. Foster, and the technique is called as two fingers method. And later, because of the disadvantages of this Foster's method, because of the thickness of the soft tissue lip or the lip thickness, the J.R.E. Mills is the one who modified this two fingers method into an intraoral method. Then Ballard and Wayman, they are the ones who developed the British classification of incisors, and it was based on the work of Backlund. And the classification, the British classification of incisors with that you now see in the textbooks is modified by Williams and Stephens. So initially, the classification was given by Ballard and Wayman. It was based on the work of Backlund, and then it was modified by Williams and Stephens. Now, Morton Katz, he's the only one who classified malocclusion based on premolars. And we can see the Katz classification. According to Katz, the classification is completely depending on the position of the upper first premolar. The maxillary first premolar should be occluding in the embrasure which is created by the mandibular first and second premolar. So the cusp tip of maxillary first premolar should occlude at the embrasure between or the contact point between the mandibular first and second premolar. So this is called as Katz's class 1 premolar relationship. If the maxillary first premolar is in front of this relation, then it is a class 2. If it is behind, it is called as a class 3 premolar relationship. So if it is in front, that is, if it is a class 2, then it is indicated by a positive sign, and we can measure how much it is in front, and we can, if it is 3 mm in front, we can say it as +3, can indicate it with a +3 sign. And vice versa for class 3 premolar relationship. So that's about Katz's premolar classification. Now going to see this question, which Katz's classification of premolars is presented in this image? See the relationship. See, this is the point where the maxillary first premolar has to be in class 1 malocclusion. Now, the premolar is in front of this contact area, hence this is a premolar class 2. So you can expect such questions based on images, and they can also give clinical photographs. So based on the photograph, try to identify the teeth, and based on the relationship between the upper and lower dentition, we have to identify what kind of malocclusion it is. Moving on to the next question. Supraversion leads to. You can easily delete open bite and scissor bite. Now you may get confused with why I deleted this. Now I'll explain why. See, the supraversion means over-eruption of tooth compared to other teeth in the arch. The term supraversion is used as a method to classify intra-arch relationship. This is not an inter-arch relationship classification. It is a classification used to, or a nomenclature used to, used to indicate the intra-arch relationship. So the supraversion is the over-eruption of a tooth or teeth compared to other teeth in the arch. So the answer is deep bite. Why deep bite? See, in cross bite, you can see that if there is anterior cross bite, there is a reverse overjet. In posterior cross bite also, there is a reverse overjet. So there is no supraversion. There is a chance of rolling, or linguoversion is linguoversion or buccoversion can be a reason, but never a supraversion. Then open bite, you may think about that vertical growers or open patients in which there is over eruption of the posteriors. Actually, in vertical growers or in open bite cases, there is no supraversion. It is actually over eruption of posteriors as a part of growth and development. It is not a malocclusion. It's not an intra-arch malocclusion. Entire posterior segment will be supra-erupted. So you cannot say that the supra-eruption of the posteriors is supraversion. So scissor bite, thinking about scissor bite is a buccal non-occlusion in which the lingual cusp or parallel cusp of the upper arch is getting contact with the buccal crest of the lower arch. So scissor bite is also because of linguoversion or palatoversion. Now about deep bite, the supraversion of upper and lower anteriors or upper or lower anteriors. I'll tell once again, supraversion of upper and lower anteriors or upper or lower anteriors can lead to over eruption or supraversion, which creates an increased overbite. So the supraversion can lead to deep bite. Now see this question. In case of anterior deep bite, what will be seen? The options are upward roll of mandible, downward roll of mandible, upward pitch of maxilla, downward pitch of maxilla. Now we have to discuss about pitch, roll, and yaw. See this image. First one is pitch. So pitch is the upward or downward rotation of an arch or a bone. So pitch can be upward or downward rotation of the arch or the bone. So the rotation happens in a transverse axis. See, the red line shows pitch. So the axis of rotation is a transverse axis. And the movement occurs upwards and downwards in a sagittal plane. So you can expect questions describing these three kinds of motions. So you have to thoroughly understand this. So pitch, I'll tell once again, pitch is the upward and downward rotation of a bone or an arch on a transverse axis. See this red line, transverse axis, and this is happening in the sagittal plane. Okay, now about roll. Roll is again upward and downward rotation of the bone or an arch, but the axis has changed. Here the axis is antero-posterior axis, and the rotation takes place in coronal plane. The first one was pitch, in which the rotation is in upward and downward direction. The axis is transverse, and the rotation happens in sagittal plane. Just imagine your external auditory meatai. You just imagine a line passing through the external auditory meatai. That is a transverse axis. Now imagine the opening and closing of your mandible. It is happening in the sagittal plane. So that is about pitch. Roll is something happens in an antero-posterior axis and in a coronal plane. So upward and rotations, downward rotations happening in coronal plane and antero-posterior axis is called as roll. Then coming to yaw. Yaw is again a rotation, but it happens in a vertical axis. The axis is truly vertical. See the blue line, the axis is vertical and the plane of movement is transverse plane. So along this vertical axis, rotation happens along the transverse plane. So the mesial or distal or side to side, right to left movement of this arch or the bone can be called as yaw. That's about pitch, roll, and yaw. Now see this question. Anterior deep bite. You have to name the anterior deep bite. Anterior deep bite means there is a vertical movement of either maxilla or the maxillary or mandibular teeth. See, so you can easily rule out the option A and B because it is telling you about roll. Now we have to confirm what is which among the option C and D. Option C shows upward pitch of maxilla. Upward pitch of maxilla means the maxillary anterior region is upwards and the posterior region is backwards. So it can't be upward pitch of maxilla. And the upward pitch of maxilla is leading to or may lead to open bite. Downward pitch of maxilla. Downward pitch of maxilla means there is a downward rotation of maxillary anterior region and upward rotation of maxillary posterior region. So the correct answer is downward pitch of maxilla. So deep bite is caused by downward pitch of maxilla. So upward pitch of the mandible is the one can cause anterior deep bite. So downward pitch of maxilla and upward pitch of mandible can cause anterior deep bite. Moving to the next question. Transverse canter occlusion. We see facially is described by, as I said earlier, that means you are seeing the coronal plane and there is a transverse cant. That means the axis of rotation is anteroposterior. So what happens there is roll. So for all these kinds of questions, try to imagine what they have described and then try to answer correctly. Now going to an application level question. In a 10-year-old boy, SNA angle is 78 degrees and SNB it's 80 degrees. Which type of appliance will be used in this case? Now, based on these cephalometric parameters, you have to identify what kind of malocclusion it is. See this chart. SNA, that means the angle between SN plane, cranial base and point A. Point A is the point present in the maxilla. So SNA gives the sagittal position of maxilla. The normal value is 80 plus or minus 2. That means 82 plus or minus 2. That means 80 degrees to 84 degree gives you a clue that the maxilla is orthognathic. If the value is lesser, if the SNA's value is lesser, that means less than 80, then it will be a retrognathic maxilla. If it is more than 84, then it is a prognathic maxilla. Or retrognathic means the maxilla is sagittally backwards. Orthognathic means the maxilla is sagittally in normal position. Prognathic means maxilla is sagittally in front. So the normal value is 82 plus or minus 2. So here, this chart gives the SNA angle 82 indicates a maxillary retrognathism. That 78 means it is less than 80. That means retrognathic maxilla. Then what about SNB? They have mentioned that the SNB is 80 degrees. The normal value for SNB is 80 plus or minus 2. So it comes under normal range. So that indicates an orthognathic mandible. So the problem here is maxillary retrognathism. So we have to correct the retrognathic maxilla. Now they have mentioned that the age of the patient is 10 years. In a 10-year-old patient, for a retrognathic maxilla, you have to pull the maxilla forward and downward. The appliance used for it is a reversible headgear. So the correct answer is reversible headgear for the maxillary retrognathism. Now tell me what will be the values if the chin cap to be used. Chin cap will be used if there is a mandibular prognathism. So if it was a case of mandibular prognathism, the SNB might have been more and SNA might have been normal. See this question. Which of the following anchorage is present in light wire technique? Now you have to know what is this light wire technique. For this, you have to thoroughly read the fixed appliance techniques. The light wire technique is actually another name for a Beck's appliance. It is a fixed appliance, fixed orthodontic appliance, which was put forward by Raymond Beck. So in Beck's technique, what they did is, see, this is the Beck's, these are the Beck brackets, and this is the Beck's molar tooth. Beck actually did the fixed orthodontic treatment using round wires. He didn't use any kind of rectangular wire. Instead, he used light wire, very smaller size round wires. Actually, what is this simple anchorage? Simple anchorage means, so I'll just describe these options first. So simple anchorage means resistance to tipping. Tipping means mesodistal movement of the crown or root. The crown is called as the tipping type of movement. So if the crown is tilted distally, it is a distal tip. So resistance to tip, when resistance to tip is used as an anchorage, then it is called as a simple anchorage. Reciprocal anchorage is nothing but if the force is used for the movement of two different units, each other. For example, in a midline diastema case, you have to move both the central incisors towards each other. So you are using each of the teeth, each of the central incisors as anchorage unit, and the resultant is movement of both the teeth. So reciprocal movement is used as an anchorage. That is why called the reciprocal anchorage means. Reinforced anchorage means to aid in retraction or aid in tooth movement of one unit, you are adding some other mechanics or mechanotherapies or different appliances to reinforce anchorage. It is also called as augmented anchorage. And the fourth one is stationary anchorage. Stationary anchorage is currently used in the straight wire appliance in which you are using rectangular wires. So examples for reinforced anchorage are your headgear, lip bumper, then transpalatal arch, transpalatal arch, etc. Even your tabs can also be considered as reinforced anchorage, which is currently termed as absolute anchorage or infinite anchorage. Now about this Beck's appliance, just see, he is using a smaller size or smaller dimension round wires, in which he gave tip back bends. So you can see the image. There is a bend just mesial to the molar in the arch wire. When you passively keep this arch wire inside the molar tube, the arch wire will be near the vestibular fornix. See the upper arch, it is in the upper vestibule. In the lower arch, it is near the lower vestibular fornix. That means when you keep this arch wire inside the bracket, you have to keep the wire inside the bracket. Then this passively placed portion inside the molar tube will be going like this. So it will create a distal tip tendency to the molar. And the molar is a very big tooth with 3 roots. It will resist tipping. So what Beck did is he used this resistance to tipping by the posteriors as an anchorage for the retraction of anteriors. What he has done is he has given this tip back bend so that the molar is maintained in resistance to tipping. He gave force to retract the anteriors. But actually, since the root surface area is lesser, they are tipped distally first. So in Beck's technique, there is no bodily movement first. Instead, he has tipped the anteriors posteriorly to close the space. Once the anteriors are tipped posteriorly, then he gave some springs to upright the roots. So initially, he gave the back bend in the arch wire. Then he kept the arch wire inside the brackets so that there is a tendency for tipping in the molar area. Then he gave forces or in the upper and lower arches to tip the anteriors backwards. Tipping means there is crown movement only. So there will be tipping of the anterior region. Okay, and by the tipping, there will be close proximation between the anterior and posterior teeth crowns. Now, then he has to upright the anteriors. For uprighting, he has used different kinds of springs to upright the roots. The details of which is not actually required for you. Now you have to just concentrate on what kind of anchorage is used here. Only thing is the resistance to tipping is used by him and it is the simple anchorage. So the answer to this question is simple anchorage. Now see this question. Identify the type of tooth movement. This is a question from Biomechanics. And for this, you have to go through the different kinds of tooth movements. Now see this image. The center of resistance is actually the point or a portion on the tooth in which if we apply a force, it will result in a translation of pure bodily movement. That means if we apply a force, see this image, which I am showing with the cursor, see this image, in which you can see an arrow mark. So if we are applying a force through that particular point, that will create a bodily movement, or all the points in the body will move in same direction. So if you can identify that point in a tooth, it is called as center of resistance. Now, clinically or practically, we may not be able to give a force through that particular point because it will be embedded inside the root portion. So you cannot give any force directly through the center of resistance. So generally, we will be giving a force through the crown. When we give a force through the crown, there is a rotational tendency. So based on this rotational tendency, we have classified different kinds of tooth movements. Now, if the tooth is moving as shown in figure, the first figure. See the first figure, this is the point, this is the position A. Position A shows the long axis of the tooth. Position B shows the post-movement position. If the tooth has to move from position A to position B, the crown and root both will be moving. So the crown will be moving in a lingual direction and the root will moving in a labial direction to become in a position in this position B. So there is a rotation for this too. Since the crown is moving lingually and the root is moving labially. So this rotation will be having a center, which is called as center of rotation. Okay. So in uncontrolled tipping, there will be increased movement of the crown and the root in opposite direction. So if you give some amount of force to their tooth and the crown and root are both moving in opposite direction, then it is called as uncontrolled tipping. And please learn that in uncontrolled tipping, the center of rotation will be near to the center of resistance. The black dot denotes center of resistance, that red dot denotes center of rotation. So in uncontrolled tipping, both will be nearer. So the center of rotation will be near to the center of resistance, and it is termed as uncontrolled tipping. Now coming to control tipping. Control tipping means there is rotation, but yet it is controlled. That means there will be some amount of movement of the root and very much movement for the crown portion. See the position A, which is the actual position from which the tooth has moved to the position B. Here you can see that the center of resistance has also moved. And when you see this rotation, the center of rotation is near to the apex. So in control tipping, there will be more movement for the crown portion and minimal movement for the root portion. But the movements will be in opposite direction. And in case of control tipping, the center of rotation will be nearing the apex of the tooth. Now see the third figure. It is the root movement. See, the tooth is moving from position A, in which the root is labial, crown is lingual. It is a retroclined tooth or lingually inclined tooth. Now we are moving this tooth to the normal inclination. That means the crown will be moving far away. And sorry, the root will be moving far away and the crown will be maintained here. There will be minimal movement for the crown tip and the root will be moving farther. So the root movement will be having the center of rotation near the incisal edge. And the center of resistance will be moving from one point to another. This kind of tooth movement is generally called as a root movement. Now there are two kinds of root movements. If the root movement happens in labiolingual direction, if the root movement happens in labiolingual direction in anterior region, bucco-palatal direction in posterior region, it is called as torquing. So the root movement, the first kind of root movement is the labio-palatal direction or bucco-palatal direction of the root. It is called as root movement. Now there is another kind of root movement in which you can see this canine. This canine is having a distal tip. The crown is moved distally. Now we are moving it into a normal position in which the crown has moved very minimally, but the root has become upright. This kind of tooth movement or root movement in mesiodistal direction is called as root uprighting. So the labiopalatal direction, the tooth movement is happening in the labiopalatal direction. It is called as torquing. If the root movement is happening in a mesiodistal direction, it is called as tooth uprighting. Now, coming to the next figure, this is intrusion and extrusion. So when you give a particular force which can intrude and that is passing through the center of resistance, then it is called as bodily movement. And this true intrusion and extrusion are bodily movements in which all the points will be moving in the same direction. For this movement, the center of rotation will be at infinity because the tooth is moving like this very minimally in along the long axis of the tooth. For this kind of tooth movement, this is also a bodily movement in which the center of rotation will be at infinity. The same is for bodily movement in a labiopalatal direction or buccolingual direction. So for all kinds of translation, the center of rotation will be at infinity. And see the center figures in the lower portion. So this is pure rotation in which both the crown and tooth are moving equally, and it is called as pure rotation. So these are the different kinds of tooth movements. Now we are going back to the question. See, identify the type of tooth movement. Just see the image. He has given an arrow. That means the dotted one shows the initial position and the shaded one gives the final position. Here, see the crown has moved very minimally and the root has moved much. And this is happening in a labiolingual direction. That means this is an example of torquing kind of tooth movement. So the answer to this question is torque. Now, another question from biomechanics. 10:1 ratio in orthodontic movement results in. So here we have to go through what this 10:1 ratio actually means. See this image. The red circle shows the apex of the tooth and the black dot shows the center of resistance of the tooth. Generally for academic purpose, it has as a rule of thumb, it is mentioned that the point of force application and the center of resistance is considered as 10 millimeters. So this perpendicular distance between the center of resistance and the point of force application is usually considered as 10 millimeter. This can vary based on different aspects because in persons or in patients, there will be change in size of the tooth and change in the alveolar bone support. So for an academic purpose, this is considered as a 10 millimeter length. Suppose we are giving a force of 200 gram at this point on the crown. Now, since the forces which is applied away from the center of resistance, there is a tendency for rotation. This tendency for rotation, when a force is applied to the tooth, is called as moment. So this is the moment. So because of this 200 gram of palatally directed force, which is acting 10 millimeter away from the center of resistance, there is a moment which is clockwise in direction. And the magnitude is 2000 gram millimeter in clockwise direction. So the force into perpendicular distance gives the magnitude of the moment, and the direction is clockwise direction. So this is the moment created by this particular force. So when we are applying this simple force, it will give a rotation and it can lead to rotation or uncontrolled tipping of the crown. So to obtain sufficient bodily movement or translation motion, we have to provide a counterclockwise moment for this. Okay, so suppose if we are giving a force of 100 gram, which is directed labially on the palatal aspect of the tooth, and it is away from the center of resistance by 20 millimeters. So the red arrow shows the initially applied force, which has created the first moment M1. Now to avoid tipping or uncontrolled tipping, we are giving an opposite force, which is coming from the palatal aspect, which is having 100 grams in magnitude, and it is acting 20 millimeters away from the center of resistance. Now see, this force is also acting away from the center of resistance. So because of this force, there will be another moment, which is in a counterclockwise direction and whose magnitude is again 20 to 100, that is 2000 gram millimeter. Now, these moments are equal in magnitude, opposite in direction. So these two moments will cancel each other. Okay. Now see, the net moment is 0 gram millimeter. What about the net force? A palatally directed force of 200 gram, which is acting against a 100 gram force, which is directed labially. So the net force is 100 gram force, which is acting palatally. So the net moment has cancelled, net moment is 0. And because of this palatally directed 100 gram of force, the tooth will move in a translation motion. Now, when we are assessing or when we are considering the moment to force ratio, you have to understand that the M moment, it is not the moment due to this force. This is the moment due to the opposing force. So M to F, moment to force ratio, actually means moment of the counterbalancing force, because to counterbalance this moment, we have given another force. So this is the dimension or the magnitude of the moment of the counterbalancing force to the applied force. So we are assessing the ratio between the actual force that we have applied and the moment created by the opposing force. So when we consider the distance between the center of resistance to point of application as 10 millimeters, then the ratio 5:1 will be giving it uncontrolled tipping. That means the moment is lesser. The counteracting moment is lesser. So it will create an uncontrolled tipping. If you are increasing the moment, then the value will be more. That means the counteracting moment is more. That means it will give a controlled tipping. Suppose it is 10:1. That means the moment, because of the counteracting force, is 10 times that of this force. That means which is equal to the distance between the center of resistance and force of application, point of force application. If it is 10, then it is a translation. Now I have a question. Suppose this distance was 12 millimeters. That means this force is applied about 12 millimeters away from the center of resistance. Then only the ratio 12:1 will give you translation motion. Okay, so this number is actually the distance between the center of resistance to the point of force application. And if the value is more than 10, that gives a root movement. That if the value is more than 10 means the counteracting moment is more than 10 times of this force. That means the counteracting moment will be more than the actual moment. So opposing root movement will happen, and that will create root torquing. So that's about this moment to force ratio. Now I have to add one more point. According to Profit, the ratio between moment of the counterbalancing force and the force applied, if it is 1:7, it will produce control tipping. The ratio, if it is 8:10, it will produce a bodily movement, and the ratio greater than 10, it will produce a torque. These values are given considering the size of the root and the distance between the center of resistance to the point of force application. So please try to by heart all these values so that you can easily answer such kind of questions. Now going to the next question. So the answer for the previous question is the 10:1 ratio in orthodontic movement results in translation. Now moving to the next question. The moment of couple, MC means moment of couple, is the counter moment, and to moment of force, the ratio of moment of couple to moment of force is 0. What is the type of orthodontic tooth movement? So we have mentioned in the previous question that there is a counteracting moment or counterbalancing moment because of the counterbalancing force. So what is this couple? Couple is actually non-collinear forces which are acting in the same body and same plane. That means they are not in the same plane. They are not in the same line. That is what meant by non-collinear forces. If the both forces are opposite in direction and acting on the same body, it will rotate. That is called as a couple. Now, what is moment of a couple? For that, we will be going to the previous thing. See again, see this is a tool in which at a distance of 15 millimeter, we are applying a force of 200 gram. So because of this force, there will be a moment which is having a magnitude of 3000 gram millimeter in a clockwise direction. We have to give, for translation, we have to give a counterbalancing force of 150 gram about 20 millimeters away from the center of resistance, so that 3000 gram millimeter of moment is acting, which is counteracting this actual moment. So in clinical scenario, we are unable to give such a force from the palatal side. Either in a removable appliance or in a fixed appliance, it is very difficult, or it is nearly impossible to give a labially directed force, this much of force from the palatal side. So in fixed orthodontics, we are giving this method in which a twisted rectangular wire is kept inside the bracket. See how this wire is twisted. It is twisted counterclockwise direction. in a counterclockwise direction. So when you actively keep this inside this slot, see this angulation of the wire, and we are forcefully keeping it inside the bracket. So it will tend to rotate to its initial position. So this is the bracket slot. This is the actual shape of or twisting of the rectangular wire. We are forcefully keeping it inside the bracket slot. So it will tend to rotate like this. That will create a couple in the bracket, which is acting in an upward and downward direction at the corners. So there is an oppositely directed non-collinear forces, a pair of forces present in this bracket. This creates a couple. So because of this couple, there will be a moment. That is why it is called as MC or moment of couple. Now, based on the moment of couple, if the ratio between the moment of couple and moment of force is 0, that means the numerator is 0. MC by MF, that it equals to 0 means MC is 0. That means moment of couple is 0, that we are not giving any kind of counteracting moment. Then there will be pure tipping. The tooth rotates around the center of resistance. If the ratio is more than 0 and less than 1, that means some amount of moment of couple, a counteracting couple is there. The moment is there. That means there will be control tipping. That means there will be some amount of root movement and more of the crown movement. If the moment of couple to moment of force ratio is 1, that means the both moments are equal in magnitude and opposite direction, and they are cancelling each other. That means, as shown earlier, there will be only the force acting, the net moment will be 0. So the moment to couple to moment of force ratio is 1 means there will be bodily movement. Then the final option, the moment of couple to moment of force is more than 1. That means if it is more than 1, that means moment of couple is more. That means counteracting moment is more. This will give a root movement in Leeway pattern direction. That means there will be torquing of the root. So this is from Profit textbook. Please by heart all these values so that and before by hearting you have to understand what it is, and then you just try to by heart this. It will be very helpful for you to answer so many questions coming from this area. Now we are going back to that question. If the moment of couple is a counter moment and the moment of force is the moment by force, MC to MF ratio 0 means there is no moment of couple. So there will be pure tipping. So these options are actually taken from Profit. So in Profit, it is mentioned that it is pure tipping. That is why the correct answer is pure tipping. Pure rotation is not a correct terminology to use in a clinical perspective. That is why the pure tipping is the most correct answer. Now, this question, given pick is an example of. The options are 3 couple force orthodontics, 2 couple force orthodontics, 1 couple, and absolute anchorage. Definitely, this is not absolute anchorage. Absolute anchorage is associated with temporary anchorage devices. And in the figure, they haven't given any kind of TAD. So the option D can be eliminated. Now we have 3 options, 1 couple, 2 couple, and 3 couple force systems. Now we have to think about what are these couple systems. I have already mentioned what is a couple in the bracket, right? In the previous option, I'll just go to that. See here, the bracket is placed inside. Because of that twisting, there is a couple, and this couple creates a moment. So that is what meant by a couple. Now, see this question in which they have given that this wire, the piece of wire, the distal end of the piece of wire is going into the molar tube. This is the molar tube, and this is going into the molar tube. And they have already drawn a couple there. That means the angulated wire, when kept inside this molar tube, there will be a couple, and there is only one couple present in the system. And see on the canine, it is actually ligated to the bracket using a ligature wire. If this wire is kept inside this bracket, just imagine if this wire is kept inside the bracket, there is an angulation, right? So this is the initial position. This is the final position. If this angulated wire is kept inside the bracket, similar to this molar, there will be a couple here. So if such a couple was here also, it would have been a two couple force system. Instead, they have just ligated to the bracket. It is not inside the bracket. So it is a point contact. Because of that, there is no couple acting on the canine. Only couple acting here is on the molars. So this is an example for one couple system. So examples for one couple systems are cantilever springs, auxiliary intrusion or extrusion arch. That means auxiliary means they are not actually inside the bracket, they are outside the bracket. And two couple systems are utility arches and created by interbracket bends. Utility arches means for intrusion extrusion, if you are keeping that inside the bracket, then there will be a couple and it is a two couple system. And similar, the interbracket bends is shown here. As I said earlier, if this piece of wire was kept inside the bracket, then this would have been a two couple system. So that's about one couple and two couple systems. So this answer to this question is one couple force system. Now, see this question. Image showing a tooth movement with values of force given as 120 gram and a distance of 10 millimeter. What is the moment of couple here? To answer this question, all the knowledge that you have gotten from the previous 3-4 questions is necessary. Just very closely observe this image. This is the initial position. The shaded one is the initial position of the tooth. F is the force given. D is the distance between center of resistance of the tooth to the point of force application. Moment is F into D, force into distance. So the moment, because of this force, because of this applied force, the moment created is 120 gram into 10 millimeters. That means 1200 gram millimeters. And the direction is also showed here, which is clockwise direction. You can see the arrow marks. This shows the direction of the moment. Now, see the movement has occurred. The post force to this like this. That means the crown has moved palatally and the root has moved labially. So if they have asked for the moment of the couple, if the moment of the couple was equal to the moment of force, if the moment of the couple was equal to moment of force, then this would have been a bodily movement. So if in a bodily movement, the root and crown should be moving in a straight line. But what the image shows is an uncontrolled tipping. An uncontrolled tipping is shown in this image. For an uncontrolled tipping, the moment of couple should be less than moment of force. For an uncontrolled tipping, moment of couple should be less than moment of force. So the value should be less than 1200 gram millimeters. So we have two options, option 2, option 4 as 1000 gram millimeter. Now we have to identify what is the direction. You all know that the moment due to this force is in clockwise direction. So the counterbalancing moment will be in counterclockwise direction. So the correct answer is 1000 gram millimeter in counterclockwise direction. So I hope you could understand what are all these concepts which we discussed today. And please go through the textbook, try to understand deeply and thoroughly, and please learn all the topics very clearly. If you are not understanding any points, please read again and again, try to understand, because certain questions may come testing your depth of knowledge, and they may confuse you with values. So you have to have thorough knowledge about all these concepts to correctly answer the questions. So it's very important to know all these things. Okay, going to the next question, which is wagon wheel effect in orthodontics. This is actually very rarely asked concept from in a UG level. This is actually a PG level question. So what is wagon wheel effect? See this image. The first image shows 4 rows of wires which are welded to a straightened steel wire. So this is in the same plane. This is the rectangular wire, and these are the rods which are soldered 90 degrees to the plane of this arch wire. Suppose you are making this arch wire into a U shape. or a catenary curve shaped arch form. This is an arch form. Since the angle between these two is 90 degrees, all these rods will be maintained in 90 degrees. So here you have to know what is torque and what is tip. Torque means, as I said earlier, the labiopalatal movement of the root is called as torque. The mesiodistal movement of the crown is called as the tip. So see this image here, the arch form is made and there is no change in tip or torque. That means they are still perpendicular to the plane. Okay, suppose we are adding torque to these rods. That means we are giving a lingually directed movement for this rod. That means this tip of this rod is moved lingually. When we move all these four rods lingually, you can see in the image C, there is approximation of these rods in a mesiodistal dimension. We are adding 5-degree torque here. That means the rod has moved lingually or palatally. But when you see from the front, you can see that there is a tip which is created because of the torque. When we add on torque further, these will approximate further. That means when you, in an arch form, that means in an arch form, when you add torque, the tip is lost because for natural dentition or normal dentition, the tip will be distally directed. That means for all the natural dentition to look better, the roots of all the anteriors will be more distal than the crown. That is what called as tip. Now here what happens is when we are adding torque, the tooth will be moving in opposite direction than what is required. Usually it should be directed distally. Because of the added torque in this arch form, it is moving easily. That means you are losing tip. So this loss of tip because of addition of torque is called as wagon wheel effect. That means it is becomes like a wagon wheel. So once you are adding torque, the tip is lost. That is what meant by wagon wheel effect. So the correct answer is tip is less as torque is added. So that's about today. As I said earlier, please try to understand the concepts in orthodontics. Orthodontics is very volatile subject. Uh, if you keep on revising the topics, it will be very easy for you to answer the questions. If you are failing to revise the portions, it will be very difficult for you because the options will be very confusing. So keep on revising, learn, read, and please do revise. Thank you so much and good night.